Hello everyone. So my name is dry eye disease my topic is my dry eye disease in a patient with rheumatoid arthritis, which is unmasking secondary Sjogren's syndrome. So we had a 43-year-old female came to an IOPD with chief complaints of irritation, burning sensation, grittiness, foreign body sensation, DOV and mild pain in both eyes since 10 to 15 days. She was relatively asymptomatic 3 to 4 months back when then she developed all these symptoms, which was followed by diminution of vision and mild pain in both eye, which was gradually in onset, progressive in nature and worsens by the end of the day and not relieved by any eye drops. Also, she had complaints of dry mouth for the past 2 to 3 months, which was again gradually in onset and progressive in nature, and she had a constant urge of drinking water. And also with a joint stiffness in early morning, which gradually improves as the day passes, and there was no any association of watering from both eyes, diplopia, difficulty in closing eyes or DOV at night. She was already a diagnosed case of rheumatoid arthritis since past 2 years and has been on the treatment for the methotrexate and hydroxychloroquine. History of contact lens wear was occasionally, and lubricating eye drops she uses occasionally. There was no any other history like eye surgery or any ocular trauma or installation of topical medications other than lubricating eye drops. There was no any chemical exposure or any radiation exposure and other systemic illness than rheumatoid arthritis, hypertension or diabetic mellitus. So on examination, she had a visual acuity in right eye, counting figure 5 meters, and in the left eye 618. With following there is a BCVA and near vision. Her NCT in right eye was 12 and in 15 in the left eye. So we had ocular examination done where in the right eye she had few filaments with EP defect of 2 by 1 mm with superficial vascularization and variable depth corneal opacity. And in the left eye there was few SPKs and else was normal. So we had some investigations done where the test for the tear film volume assessment we had done Shermer test, another is T-Butt test and corneal vital stents. We also done impression cytology. We showed amount of goblet cells in the case of dry eye which was significantly reduced. So following the Shermer test in our patient there was 4 mm in right eye and values for the left eye was 12 mm which was severe in right and mild in the left. So we also done the T-Butt test. We showed in the right eye there was 4 seconds and in the left eye there was 5 seconds. And also the fluorescein clearance test, which normally the dye cannot be detected at 20 minutes, but in our cases there is a delayed clearance. And for the corneal vital stents we had done fluorescent dye 2% strip, which showed these findings. For the right eye there were multiple filaments, and in the left eye the lusterless cornea. Blood investigation showed raised ESR and CRP along with the positive RF factor, and minor salivary gland biopsy showed some lymphocytic infiltration. This is the revised American European criteria for diagnosis and classification of dry eye disease, which is the ocular symptoms, oral symptoms, ocular signs and histopathology along with the oral signs and autoantibodies. So following all the criteria which usually we do for the diagnosis of secondary Sjogren's syndrome in the patient with the defined connective tissue disease or presence of any one symptom or plus 2 of all the signs objective categories must be met. So we had some differential diagnosis in our case, but like conjunctivitis or lead abnormalities, severe MGDs. So there were the treatment options as per the DUEs, level 1 to 4, and these are the 4 levels which has been recommended for the treatment, but we usually give a blanket therapy for the dry eye disease. So I will directly jump to what we can do in our patient. So we started for the right eye and acetylcysteine 4% eye drops QDS, Moxie QDS and fluorometholone cyclosporine, and 2:1 alternate hourly CMC 0.5% and SOHA 0.1% eye drops. We kept our patient on routine follow-up of 2 weeks. It was observed that there was symptomatic relief in the left eye as compared to the right eye. EP defect was healed out, and then we tried a temporary punctal plug in the right eye as well, following which there was a reduction in the filaments in the further follow-ups. So is our patient need long-term treatment? Any multiple treatment regimen can lead to poor compliance because as we started so many drops. So what measures can we take in such chronic cases?
So these NC-style drops are commercially available?
No sir, we usually make it with a dilution along with the CMC 4%, not commercially
And
available.
how long you can keep it?
On the treatment?
Once it has been prepared, so how long you can keep it?
Sir, 2 to 3 days we usually give, we follow up the patient after 3 days and we again freshly give.
So for
make it.
every 2-3 days the patient has to come back again?
So yeah, but because it is not commercially available
Yeah,
and
I
we
understand.
we
So
have
how
to
do
make
you
it very
ensure the
fresh.
compliance?
Yes sir,
That can be, I think, the problem.
yes sir.
Big problem.
That's why there is a,
So preservative. And how you had said the temporary punctal plug.
yes sir.
How long? Temporary means how much?
For
you-
the say 6 months, 3 to 6 months we can do it temporary for silicone or the hyaluronic acid punctal plugs.
And you have followed this patient up to what time?
Sir, for the 1 year. 1 year. Yes sir.
Okay, time is up, no issue. Go ahead.